This week on the BackTable podcast.
Having small needle approaches, people, say, well, we need to have a smaller needle approach because it's less painful afterwards. Okay, in general, that's a pretty good rule, and I don't dispute that. But this is bone augmentation. Show me in bone augmentation where that applies. There's no evidence for that. Show me in bone augmentation where that does not apply. Okay, the SAKOS trial. You have 11-gauge needle with bone kyphoplasty compared with 4, 6, and 8-gauge devices for the spine jack. And in the SAKOS trial, in the short term, 1 month and 6 months, you have statistically significantly increased amount of pain relief. Same thing as saying decreased pain, significantly decreased pain in patients that had the larger gauge needle than those that had the smaller gauge approach. So there's more to bone pain, there's more to fracture pain, there's more than just what you use to do the invasion. It maybe has something to do with the adequacy of treatment.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. First, a brief message from our sponsor. Stryker's interventional spine business offers the control you need, the flexibility you want, and the quality your patients deserve. Stryker is your partner in making healthcare better. From technology to training, from reimbursement tools to patient education, Stryker is there to support you every step of the way. Innovation is the driving force at Stryker. Their extensive product portfolio for vertebral augmentation and radiofrequency ablation procedures ensures that you have the tools needed to provide top-notch care. But their commitment to advancement doesn't stop there. With recent additions like the OptiBlate bone tumor ablation system and FDA 510(k) clearance for the spine jack system for compression fractures that result from malignant lesions, myeloma, or osteolytic metastasis, you'll be eager to explore all the solutions Stryker has to offer. Learn more at www.strykerivs.com. Now, back to the show. Hello, everyone. This is your host, Jacob Fleming. Welcome to part 2 of our discussion on sacroplasty with Dr. Beall. If you haven't already listened to part 1 from last week, do so before you check out this one.
We need to really expand the number of people doing sacroplasty, and we'll see concerted effort to do that. That's one of the reasons I developed the sacroplasty curriculum.
And big shout out to that upcoming curriculum. I think that the course sponsored by Stryker will probably be up and rolling soon. So the curriculum has been completed. And so this is something I've been saying for a little while in the couple of years I've been going to vertebral augmentation courses is, hey, we need to have a station in the lab where we do sacroplasty. We need to do this. And, there's clearly a recognition that there's something people want to add to the armamentarium.
And we can think about adding that on to the fellows course for the Saddle Science Foundation. We just finished our SSF course and image-guided spine intervention course, IGIS course there. And it was, I think, very successful, a lot of interest in it, and a lot of things and this was developed to feature things that are new and cool and otherwise awesome to add to your treatment armamentarium. And the IGIS course is really focused on people that are in practice, people that are in fact advanced in terms of image-guided spine intervention treatment, and that are looking for that little extra tip and trick and things. So, that might not be a bad thing as an amalgam to put on that. It's a little bit crowded in terms of things that we can feature, but for the fellows course at the Seattle Science Foundation coming this November, and be watching out on social media. Follow me on Twitter at Doug Beall, 2 L's, and on LinkedIn, and you'll see multiple notices about how to sign up for that course. So you fellows out there to be present in 1 year pass are all candidates to go to this course, and it's a hands-on. It's got a didactic and a hands-on lab, and the facilities are, bar none, just top-notch.
Absolutely agree with that, having just returned from that course as well, and just always an excellent experience. And for those who have not been able to make it, I'd highly recommend the YouTube content, but it's nothing compared to the in-person experience. And so as a preview to that some people will have the opportunity to get involved with in the near future, let's just give a preview of kind of the basic technique, the fluoro technique of sacroplasty. I think that the CT technique is somewhat self-explanatory as long as you're talking about just doing a what we call short axis approach.
Yeah.
But what I like about fluoro a little bit better is the ease of doing both a short or a long axis approach, as well as transiliac, which is another story. But why don't you just walk our listeners through the basics of the fluoro guided approach?
So whenever you have a CT guided approach, typically you put a patient prone and you'll put the needle down into the sacrum at the same obliquity in an axial plane that the patient is lying on the CT scanner. And as Dr. Fleming pointed out, that's usually an axial approach. Commonly in people that don't have, if they have a little bit more of a dorsal flip of the sacrum, it will turn out to be a hybrid approach. So it's not really short axis where you square off the superior end plate of S1 and you come in parallel to that to S1, square out the vestigial disc of S1, S2, come in parallel to that kind of an axial access point to the sacrum. That is an axial or short axis approach. That is what a short axis approach is. If you take the longitudinal axis of the sacrum, and the short axis is going to be seen coming directly in parallel to the S1 end plate on the sacral outlet view, pelvic outlet view. And then on the pelvic inlet view is kind of a cross-sectional view. The eye is tilted toward the patient's feet. You're looking at the prominence of the pelvic brim anteriorly. And you can either start a long axis view just medial to the posterior portion of the joint, just 1 centimeter in dorsal from the pelvic brim, or you can start it on the pelvic outlet view where the sacrum is nicely laid out to you. You can see the S1, S2, S3 neural foramina. You can see the greater sciatic notch, and you can either do it AP or you can do it contralateral oblique, where you tilt your eye along the axis of the SI joint with the starting point just above the level of the greater sciatic notch between the sacral forameter and the SI joint, and then tap, and you look on the lateral view and you put it up to the mid-body of the sacral ala. Remember that the body is different than the ala. The line that you see on the sacrum is the body. It's the body. It's the body. It's not the ala. The ala is shorter. It doesn't go up as high, and it comes out farther anteriorly. And so put it up into the middle of the sacral ala and squirt cement S1 and then retract proximally to S2. And most of the time it will go from the inferior portion of S2, posterior inferior to the anterior and superior portion of S1. Oftentimes, of course, especially if you use the pelvic inlet technique to start, you'll get a portion of S3 as well. But the short axis is done by sticking a needle in S1, another needle in S2, another needle in S1, another needle in S2. So typically for 4 needles, you can use the same needle over again if you want. So, but that's the short axis, and the long axis is 2 needles all the way down the longitudinal axis of the sacrum. So I'm going to give you a couple of advanced techniques. The transiliac view Dr. Fleming referred to, you can go right in the middle of the S1 vertebral body or right in the middle of the S2 vertebral body, making sure not to go too far anterior. And you can go all the way to the contralateral side. Now, that bone you're seeing, the shape of the sacrum that you're seeing anteriorly is the sacral body. So you have to stay posterior to that. And you don't want to get too far posterior to get in the spinal canal. That part hardly is ever an issue. But you want to stay right in the middle of S1 and S2, because at the S1-2 vestigial disc and at the S2-3 vestigial disc, you'll have the neural foramina. So if you go through the bony corridor, is what it's called, bony corridor of S1, bony corridor of S2, you can come out the other skin on the other side and you won't hurt anybody. There's avascular and aneural, and you can go all the way across S1 and cement from distal to proximal. You can go all the way across an S2, cement from distal to proximal, and that's excellent. Time out just for 1 second. All of these approaches are covered in the Comprehensive Guide of Vertebral Augmentations and the Sacroplasty chapter. Primary author in that is Kieran Murphy. So shout out to Kieran. Strong word. We have it on our shelf behind us. And the final approach is the 3-needle approach. So think of the 3-needle approach with the longitudinal axis of both sides of the sacrum, with the 3rd needle in the sacral body. And what you do, you start at S3 because you will be below the intrathecal space. You will be at the very distal tip and even beyond the epidural space down there at the very bottom often. And then you put the needle up into the sacral body along longitudinal axis to the mid portion of the S1 body. So you can use 2 longitudinal access needles, one on each ala, and a third one into the body with the same exact trajectory as you have in the ala. And that's the 3-needle technique. And then of course the hybrid technique is you just do it between the obliquity, the needle angulation that's between the axial and the longitudinal axis. So the short axis and the long axis, somewhere in between there, and that whole arc closer to short, closer to long, that whole intermediate is going to be just a hybrid approach.
And that's fine. That approach works really well most of the time. That being said, one of the most common deficiencies I see in the treatment has to do with getting in the required amount of cement. And this is something that we beat the drum on a lot in terms of vertebral fractures, and it's kind of even more of a concern with sacral fracture. So let's say that a typical sacroplasty injection might be, let's say 4 cc's. Is that going to get the job done?
Oh, it just makes me cringe to think about how little cement goes into the sacrum. And so I've heard people's rationale in a vertebral body or a sacrum. Well, I just put a little bit in it, and it works, and it's great. The patient's pain goes away. Okay, yeah, but does it stay away? And how much of it goes away? And is it durable? So there's one of the purposes of a publication of the Swiss registry was you need to put more cement in the vertebral body, because the only modifiable thing that you could do to get better and more durable pain relief was to put more cement in. That's the only modifiable thing. The other one's what's more painful, lumbar, thoracic, or thoracolumbar junction fracture, or mid-thoracic. So transitional segments, thoracolumbar junction fractures are more painful than lumbar fractures. And the only other statistical significance was who complained more of pain, men or women? The answer is men. Why? Because they're sissies. This is what the data says, not like that they were sissies, but women did complain less of pain that did men. But the only modifiable thing that you could do to increase the magnitude and duration of pain relief was to put more cement in. And so it's not okay. And there's data by Malloy, Nieuwenhuis, Martinchik, lots of data that said you need at least 15 to 25% of the non-compressed native volume to make sure you have an adequate intra-body strut. This applies to the sacrum as well. So you need to have an intra-alar strut that will transmit force, not necessarily the body, because most of the time whenever you have an H-shaped fracture of the sacrum, the horizontal bar of the H is through the mid-body of S2. Most of the time you do not need to fix that. You do not, and the vast majority of time, you do not need to fix that, because fixing the ala, but you have to have an intra-alar strut that transmits force. And if you don't have enough cement in there, you will not be able to accomplish that. And so for you manufacturers, here's listening. So the Strykers, the Merit, the Medtronic, the IZI, and anybody that makes cement, you have to have around 20 cc's of cement per batch. Anything less is not enough. So we are commonly putting our average amount of cement that we put in. So the average amount of cement in the literature that's necessary is at least 6 cc's per fraction, or 12 cc's at least total. The amount of cement that people are commonly putting in there are closer to 13 cc's. So it's even more than that. Our average is 18 to 20 cc's. That's how much we use the IZI cement, Vertifix HV cement, and that mixes up 18 to 20 cc's per batch consistently. And we use that. How commonly do you think we use all of our cement, Dr. Fleming, out of all the cases? Just all comers, so sacral and otherwise.
All comers, I would say we use it all up, maybe a quarter of the time, probably less. And with sacroplasty, it's 100%.
100% of the time. So the bottom line is, you're going to be using a lot of cement. Our average is 9% per side, at least 9 to 10% cc's per side. So, I think traditionally the people have mixed up 10 or 11, maybe 12 cc's of cement, and the manufacturers do and call it good. That's just not enough cement. It's just not enough cement for people to accomplish the volumes that we now know based on the data that I mentioned. We now know based on the sacroplasty data that has continued to creep up in the amount of cement that's added over time, keeping in mind that this has only been done really since the early 2000s in any way, shape, or form, in any significant degree. It's creeping up because people know that you need more cement to get a good magnitude and duration of relief. And so we need to be having a greater amount of cement. We need to have the manufacturers include more. I mean, this is polymethyl methacrylate. This stuff has been used since the 50s. I mean, it's not that expensive. And, it's a powder polymer and liquid monomer made out of stuff like, toluidine and benzoyl peroxide. I mean, this is stuff that is not expensive, and we need to have more of the cement. And that's primarily one of the reasons I use the cement we use now, is because it's got indicator beads. You can see the flow, which has added a whole new dimension to my perception of cement deposition in the bone. And it's about 350, 400 Pascal seconds right out of the box. So it's not really that high viscosity. It's kind of a medium to high viscosity. And I like it because it interdigitates into the interstices of the bone pretty well. And if you have something like it's 1,000 Pascal seconds, like the old confidence cement, it kind of gloops together and doesn't really go in all the directions that you want. It just is my opinion. So I'd like a medium to high viscosity, and that's what this is. We mix 18 to 20 cc's out of the box. That's good stuff. And then you need in your mind's eye, if your civil engineering of the sacrum doesn't include an intra-alar strut and the ability to transmit force, especially if you have fractured pubic rami, then you're not done. And if you do have fractured pubic rami, which is really common, I mean, what are you going to do about that? I mean, are you going to fix those too? Well, the original description of a superior pubic ramoplasty was done previously. We have described that back in 2007. So you can do that. It's an unlisted pelvic code, means you don't get paid for it, but you do that certainly with informed consent of the patient and in conjunction with a sacroplasty, just to try to get the pelvis to heal. And this is typically seen in somebody with a very poor bone quality. And who gets poor bone quality? People that are deconditioned. Who gets fractures? Same type of person. And it increases your need to adequately get them back on their feet, because these people don't have long to go before they go down. And just don't let that happen in your watch.
Yeah, can't agree more with that. And referring to the ramoplasty technique, one of the places we've used that is in a patient where she did have pubic rami fractures as well as sacral fractures. We went ahead and just fixed her sacral fractures. And you can often do that because the pubic rami don't get all that much of the force deposition, but they do get some. And so this patient ended up basically failing kind of non-surgical management, if you will, the pubic ramus fractures. And those take an even greater amount of cement. But I do want to throw out to the technique doing both at the same time, or what you've coined the radiology 360 front back approach.
Yeah, that's right. Yeah, I would encourage you to have a low threshold to do that. The people who have both fractures in front or in back are more debilitated, as I mentioned. These people need you more. And I've had occasions where people come in and we do the fractures in front and in back, and then the patient comes back 2 weeks. Oh, I feel great. And the person's working with me, and not necessarily Dr. Fleming, but in the past have said, what happens to that patient if they don't see somebody that is able to do the front and the back repair? And I guess the answer is they don't get any better. And they don't, especially if you don't do either the sacroplasty or the superior ramoplasty. I mean, it's just the luck of the draw a little bit in terms of who they see, who they get referred to, but just do your best that you can. Try to stabilize what they need to. This really is a mechanical stabilization of the bones that are unstable. And if you can just keep that in mind, that this really is the civil engineering of the sacrum, pelvis, and spine. This is just to make something that's adequately resistant to force, that is durable, that will last. This is our goal. This is, and in regard to a little bit of resistance of shear force, I've heard some misinformation been said on that news source called YouTube that Dr. Fleming called to my attention. Injecting cement into the sacrum works consistently well or better than almost anything that's done, not that you do, or that's done in toto. So yes, cement doesn't have a great resistance to shear force. Yes, there's shear forces that go through the sacral ala. That does not mean, ergo, it doesn't work for sacral insphysicy fractures. Of course it works. It works consistently. I gave you the pre and post pain scores previously on level 3 article on prospective single center trial that Cortman reported. A large U.S. registry about ready to be larger, and Chandra's meta-analysis. All of these are consistent. I mean, almost to the T. The worst one-year follow-up pain score was a 1.9. The rest of them were essentially 0.9s, under 1. So absolutely it works. And if you have enough cement in there, it does provide enough resistance. So it is a combination of compression and shear. It's not just solely shear. Lindstrom had a good article about how these fractures happen and what type of forces are transmitting through there. But this is one of those things that if people say you shouldn't be putting cement into a sacrum because it's shear force and it won't work, I would defy you to give me one piece of evidence that shows that's true. And in return, we'll give you 15 pieces of evidence with cumulatively thousands of people showing that it is very true, that it reduces pain and improves function. So this is one of those things I kind of want to nip in the bud. I think this is misinformation. I don't like this being said because it will propagate the so-called conservative, which is really not conservative. It's more risky treatment of patients with sacral insphysicy fractures. If anything, there's overwhelming data and evidence saying that we need to up our ante about getting these patients treated adequately, both in terms of the acute phase and in terms of follow-up.
Agreed. And it's important to remember, the biomechanics of the pelvis, as we've been alluding to this whole time, are complex, but there absolutely is compressive force in the sacrum, particularly in that ala where it's weakest, and this is where it fails. Of course, the force needs to be transmitted somehow to the acetabulum, and this is the path that it takes. And so while the forces are complex, I think the vast majority of these osteoporotic fractures should not require fixation with hardware instrumentation.
Some of them do, some of them don't. We kind of have borrowed from trauma, at least temporarily, that a centimeter or more should probably get screws, and less than a centimeter could probably have just cement. And I think that's an okay metric now. Moving forward on it, I'd like to study that a little bit more. And, some of our colleagues that have done quite a bit of this, Sean Tutton comes to mind. He worked primarily with cancer. But, these are the same kind of biomechanical stabilization principles. It's just the bone that's different and the type of patient that's different. But I would like to collect some data moving forward to figure out when we add hardware, when we don't. There's a trial from SI Bone that is either has started or will start on placing the screws for the treatment of sacral insphysicy fractures. I think it would work. I mean, I think it clearly works, but something tells me I don't want to put a screw in if just a cement injection with a 10 or 11 gauge jam sheeting needle would work just as well. I think the less is more, and the inverse pyramid of stomatos, where you start with the least invasive thing and then you click down to the combination of the least invasive thing that's durably effective for the patient, and you stop there. So, we have certain ideas about when we need screws, when we don't. I think we'll follow those provisional ideas until the data says differently.
And on that note, as you've referred to with the minimally invasive approach, the Sacroplasty has pretty high-tech equipment needs, including a mortar and pestle to mix cement.
Yes.
And
spoon
and bowl, and a relatively large bone trocar. But 10 gauge is typically our preference, but anything 11 gauge I think works great. Some of our colleagues have talked about using 13 or 14. I think that's fine, but from the perspective of being able to get as much cement to the bone as possible, we found that really just cement and a single or two needles is enough to get the job done.
We're not putting this into the foraminal valley, right? And this is not a Gaussian ganglion procedure. It's a sacrum. It's a big bone. The SI joint, 17.5 square centimeters of real estate. It's the largest joint we have in the body. And the sacrum is a huge bone. And typically it is not painful to do these. You start, especially with long axis technique. You start just right at the bottom of S2 or end S3. You numb up the periosteum, and these are just, you have a lot more pain from movement, injection of cement into the bone, or aspiration because of pressure changes in the bone marrow. Those are painful. What we do, putting these big needles in there, that's not painful. It's only mildly painful. So I think compare this to a bone marrow harvest, and people say, oh, bone marrow harvests are incredibly painful. Well, it's not the needle that's painful. It's the pressure change in the aspiration that's painful. And yeah, I think 10 gauge. And remember that anytime you go down needle gauge, you go down and flow, and the flow will be, it'll be more cumbersome through a smaller needle, and you won't have the ability to inject more viscous cement and have greater cement control. So, boy, in the sacrum especially, give me that 10 gauge or 8 gauge every time. Don't get caught up with having small needle approaches. People, say, well, we need to have a smaller needle approach because it's less painful afterwards. Okay, in general, that's a pretty good rule, and I don't dispute that. But this is bone augmentation. Show me in bone augmentation where that applies. There's no evidence for that. Show me in bone augmentation where that does not apply. Okay, the SAKOS trial, you have 11 gauge needle with bone kyphoplasty compared with 4, 6, and 8 gauge devices for the spine jack. And in the SAKOS trial, in the short term, 1 month and 6 months, you had statistically significantly increased amount of pain relief. Same thing as saying decreased pain, significantly decreased pain in patients that had the larger gauge needle than those that had the smaller gauge approach. So there's more to bone pain. There's more to fracture pain. There's more than just what you use to do the invasion. It maybe has something to do with the adequacy of treatment. So I would say focus for this. Good rule of thumb is to focus on adequacy of treatment. Don't focus on being elegant and having less invasive tools to the point where you sacrifice accomplishing one of the primary goals is durable amount of mechanical support for that bone.
On the note of the equipment used, you referred to earlier that some people have used a balloon. Your thoughts on the necessity of that and how that affects kind of the whole consideration, which is important, very important from, frankly, a billing perspective of sacrovertebroplasty versus sacrokyphoplasty.
I'd love to be able to use a mechanical creation device. We don't because of billing and reimbursement. And would we because if we didn't have the billing and reimbursement constraints? Yes, I could tell you I would, and I would use as much of a mechanical device as it took. So how do you fix fractures that have a little gap? How do you fix fractures that fracture through S2 and are becoming kyphotic, that have the kyphosis? Why wouldn't you put something in there to create a path of least resistance for the cement to be able to direct it, especially when you had fractures going through the anterior portion of the sacral ala and into the foramina? I mean, why wouldn't you do something with mechanical devices combining that to provide some type of permanent structural support, the spine jack of the sacrum, for example? It's a different fracture, and I don't mean to imply we should be using spine jacks in the sacrum, which of course we should not. They're not made for that, made for vertebrae, but something like it that had the ability to go along the longitudinal axis of the sacrum, had the ability to restore some of the bony anatomy, had the ability to control the cement a little bit better, create a pathway of least resistance, maybe a sacroalar stent or something like it. I mean, these are things that we need to consider. And the comment about industry, there's no industry that's paid for sacroplasty research, so we don't have any level 1 sacroplasty research. And where'd the SAKOS trial come from? Where'd the FREE trial come from? Where'd the CAFE trial come from? So Opus 1, I mean, you go on and on. So these were all industry funded, industry sponsored, and basically, and for those critics for industry sponsored trials out there, if industry sponsored trials are biased, if that's your opinion. So number one, I don't think they're biased at all, because you'd have to tell me what point along the course are they biased? Are they biased in terms of the sites that are involved, the data that's collected, the type of data that's collected, the inclusion-exclusion criteria? Are they biased in terms of who does the CRO, the data collection? Are they biased in terms of how the data is processed keeping in mind we have to have transparency in both data collection and data processing throughout the whole of our research trial. Are they biased into how the statistical significance is determined? What literature source it gets sent to? I mean, who does the review? Who's the editorial manager? I mean, what the review says, the response of us to the review. I mean, there's so many points along this time, and in the industry-sponsored trials that I have been a part of, and there have been dozens of these things, I have not seen one example of bias. I have not been pressured one time to do a certain thing a certain way because of some perceived bias and advantage that would potentially have. Not once. And so for those of you that say that there's a bias toward industry, I categorically disagree. I see absolutely no evidence of it. And if you have evidence, I'd like for you to call that out for discussion topic so we can discuss it. And if all of these randomized control trials for the literature are industry sponsored and are biased, why are they get the results less optimal than the vertebral augmentation registry and the sacroplasty registry that was studied, that was sponsored by the SIR Foundation, a society, right? So it's one of those things that, in fact, we embrace literature in trials that are sponsored by industry. They want to make new devices that are good and that do a lot of good for people, and the device they make that's slicker, better, produces better outcomes that people adapt and practitioners adopt more will be better, and these will be more profitable, and these will do more good than the devices that are clunky and not nearly as well placed. So I think we need to be working on a similar team, not the same team, but we need to be working in aggregate, and we need to provide help. And there won't be an industry-sponsored sacroplasty trial, I don't think. And consequently, we will be left with real-world data, which I think is good, especially since it's society-sponsored. And then a Category 3 trial. So I think hopefully that will protect and preserve this procedure for as long as we need it. This is something that I think in terms of data support is a little bit tenuous. I think what will give it a lot more support and a lot better foundation is when we complete the 250 patient registry, publish that, and at that point in time, I think we raise our glass and give a big cheers to Sacroplasty. Sacroplasty.
Theme song. Anytime we get to do sacroplasty, and it's appropriate because we love sacroplasty and we know the patients love it and they love the way they feel afterward. It's, as you said, one of the very best things that we can do. And but talking about moving to the next level with kinds of mechanical augmentation or even just routine balloon augmentation. So this is kind of a odd sort of idiosyncratic situation in the American health system that we see, which essentially mirrors CMS, is that there's, as you said earlier, a T code for a sacroplasty, which is sacrokyphoplasty,
right,
versus the sacrovertebroplasty. And so what's your advice to our colleagues as they're navigating this? And a lot of them will be doing the first one in their hospital, and so their coder may have never seen this before, and certainly we have seen issues with this as well. And in order to make this a viable treatment, it has to be something that is paid for.
Well, for vertebroplasty, it's either cervical thoracic or lumbosacral. For kyphoplasty, it's either thoracic or lumbar. And so for the sacrum, a sacral kyphoplasty or vertebral augmentation with mechanical device is in most places a T code. So my advice to people out there doing sacroplasty is, out of one of the 7 max Medicare administrative contracting regions throughout the United States, know what gets paid and what doesn't. If your T code for vertebral augmentation with mechanical device doesn't get paid for, don't use it. Use a lumbosacral vertebroplasty code. And if it does get paid, the T code, use it, because the T code stands for temporary, and this is done until there's enough data collected that the temporary code is allowed, done away with. And as I mentioned, we've included both kyphoplasty and vertebroplasty of the sacrum in the registry. So hopefully this will provide a little supporting data. If necessary, we can even cull it out to see the comparative results in the end. We have not done that yet. We won't do that until we're finished with the entire registry. But my guess is that it probably will be exactly the same. If anything else, maybe providing some of the pathway of least resistance and some of the mechanical devices to be able to reduce the fracture. And the sacrum breaks from top to bottom at the S2, and it breaks from side to side, and it kyphoses really at the body of S2. So, there are mechanical changes that happen. There are deformities that can happen with this. And I think it probably would be about the same. I'd like to have some data for both. But just know in your area, and, I use Medicare as an example. Of course, commercial insurance, some of them will pay for this. Most of them will actually pay for this. But most of these people, as I mentioned, will tend to be older. They'll be, 10 years older than a typical person with a vertebral compression fracture. So, literally, upper 90% for us in our practice of these will be Medicare patients.
And it definitely underlies the importance of taking swift care of these patients who are really often very fragile, being older than our average vertebral compression fracture patients even. And we've seen that this is something that helps them get up and about, which is really the whole goal. The most satisfying cases of these are a very active patient coming to you who's been totally debilitated, and them being able to walk out, us not even have to wheel them out in the wheelchair to the front, but we can just walk next to them. And it's one of the very best things we do. And to our colleagues, who I know many are really interested in learning more about this and getting to the courses, keep your eyes and ears peeled, because I think we'll have some announcements of new courses. As we said earlier, Stryker teaching course and our future Seattle Science Foundation courses. These are really great organizations that we're happy to work with as we try to get people educated about how to just deploy this technique in their practice. And once you've done it, you'll say, why haven't I been doing this?
Absolutely. A quick shout out to Emily Ponstein from Stryker, who requested the curriculum. Dwayne Olin, who supported that, as he knows as well as I do that this is something that is very much needed. So hopefully we can start the sacroplasty courses. Incorporated that provisionally into the last course we did, but that was a little bit impromptu, and I did so because people asked for it, so it was irresistible to do. So thank you guys, and hopefully we will see more of the sacroplasty courses open up in the future. I'd sure like to propagate that as much as we can.
Agreed 100%. Dr. Beall, that's all I have. Any closing thoughts for our listeners?
Well, thank you for thinking of the sacroplasty topic. It isn't really sacroplasty. It's really osteoporotic insufficiency fractures. 2 million of those per year. And out of that, the under recognition and under treatment of this is still absolutely unacceptable. And as bad as we emphasize it, as much as I grouse about this often, you look back 20 years at least over the course of our treatment, finally people are the most requested course is for sacroplasty, and having just recognized and started treating those in the last 20 years, I think that's relatively quickly. And for that, I'm encouraged by the number of people that are starting to treat the underlying disorder. And this is a scourge. It's only going to increase with the age of the population, and whether it's Asia, Europe, or the United States, the silver tsunami is coming, and we have to do something, just like I told you a dozen times. If you don't like taking care of old people procedurally, medically, and otherwise, you better start liking it, because that's going to be the lion's share of people we take care of. And as you know, a lot of our practice is dedicated to degenerative, is dedicated to problems that happen in the elderly. And having said that, one of the most, probably the most rewarding patient population to take care of is exactly those patients. So I think the future is very bright, and it's our job to try to make it brighter.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Janua Kennebrew.
Thanks again, and see you next time.